welcome, right spot. You're joining us, the Emergency Medical Services for Children Innovation and Improvement Center, the EIIC. Today's webinar will be focusing on introduction of actually two different programs to two different audiences, if not more, and we're very excited about that because this is first time happening virtually. So happy that all of us here in this room. So this is a webinar that is going to focus on introducing pediatric mental health care access programs, PMHCAs, and emergency medical services for children state partnership program. We also will talk and actually explore that partnership with our partners in Delaware. Therefore, you'll get to hear our awesome speakers from the Delaware PMHCA team and the Delaware EMSC team. The objectives for today's webinar is just that, is improve our knowledge about PMHCA program and the EMSC programs and possible measures that these programs partnerships could impact. Please remember to put your name, email, credentials in affiliated organizations in the chat, or follow instructions that Jen provided earlier through the Mentimeter. And so we would appreciate that. Please type your questions in the chat. We'll monitor that. And also feel free to unmute and ask them. So today, our speakers, please help me. I'm going to take this opportunity and introduce these incredible speakers who are joining us today. We have Rachel Alter, who works for the National Association of State EMSC Officials. It's a abbreviation that I cannot pronounce, but I'm going to spell it out, NASEMSO. As the program manager in her role, she provides staff support to the Pediatric Emergency Care Council. And EMSC Innovation and Improvement Center, Rachel serves as a state partnership domain leader, pre-hospital domain co-leader, and is also co-leader for the pre-hospital pediatric readiness program, PRP. We also would like to introduce Crystal Spence, who has over 25 years of leadership and management experience in the disciplines of health services, education, and training. And after retiring from the United States Air Force, Crystal was involved in planning, providing, and evaluating patient care and treatment in the clinic that cared for approximately 11,000 patients between the age of infancy to 65. That's impressive. She was also the pediatric flight chief for 8 years. Currently, Crystal holds a position with the Delaware Emergency Medical Services for Children manager, and she's a manager and teaches medical courses at local college. Wow. We also have with us Joseph Hughes, who is a director and coordinator of Delaware PMHCA team. And there's a lot to say about Joseph, so I'll let him talk about himself in a little bit later during this presentation. And as well, we'll have Rosie Crosby, who is a representative of Delaware team as well. Rosie has over 30 years of experience in academic, nonprofit, and for-profit arenas. Rosie works tirelessly to connect people, organizations, and resources to solve problems and to get things done. Rosie is an instructor at Johns Hopkins University Cryer School of Arts and Science. Please welcome our presenters. And with that, we're going to move on to the next slide, and I'll give the floor to Rachel.
Thank you so much, Anna. I am going to kick this off with kind of a brief history of the EMSC program, and I do see a lot of familiar names on this, so maybe you'll all learn just a little bit as well. So really, to understand the state partnership program, we need to kind of go back in time a little bit to the origins of the EMSC program. So the landmark EMSC legislation was passed in 1984, which you may have seen recent communications. This is now our 40th year celebration of the EMSC program. So this legislation was shepherded by Dr. Calvin Sia from Hawaii. He was recognizing that children's unique needs were not being addressed in emergency services. And really the EMS system, even in the 80s, was relatively new, and was really focused on post-crash care and lessons learned from both the Korean and Vietnam wars, which obviously didn't have a lot of children being taken care of during those times. So it was really adult focused. So Dr. Sia shepherded this legislation, and with the assistance of some senators from Connecticut and Utah, the EMSC legislation passed. Funding was appropriated in 85, and EMSC programs were first funded in 1986. And these first grants were provided to Alabama, California, New York, and Oregon. I have DC on there. There's a little confusion about that funding, so you can just ignore that little bullet there. This funding created some of the first strategies for addressing important pediatric emergency care issues, such as disseminating education programs for pre-hospital and hospital-based clinicians, establishing data collection processes to identify significant pediatric issues in the EMS system, and developing tools for assessing critically ill or injured children. So this funding was provided to states and accredited schools of medicine for what they were calling needs assessments or planning grants, and demonstration projects. So then using these lessons learned from the demonstration projects, in 1991, the funding focus shifted from demonstration to implementation. So they were taking the lessons learned from these demonstration projects and also from the needs assessments that were done in states, and really starting to implement best practices throughout the country. So in just a really quick side note, that little QR code down on the bottom is a 7-minute video of a history of the EMSC program through like 1986, I believe. So if you want to take a look at that after this presentation is over, that is available to you as well. Next slide. So just wanted to share a couple really early grant abstracts. So in Florida, they were looking at coordinating clinical research and educational efforts in pediatric emergency, critical, and trauma care. Next slide. Hawaii was focused on creating a vertically integrated emergency system. So really thinking about coordinating pediatric care through the continuum from that first response all the way through rehabilitation and the primary care provider. Next slide. And then Maine really looked at rural emergency care and how to replicate their work in other rural states. So they looked at training programs for both pre-hospital and hospital personnel in those rural areas, as well as a focus on educating parents of children with special health care needs and how they can best access the emergency system. Next slide. So that takes us to 1997 and the introduction of the State Partnership Program. So this program was introduced to help states improve, refine, and integrate pediatric care within the state EMS system. By this time, all states, the District of Columbia, and 5 U.S. territories had received some level of EMSC funding. So in the beginning, you saw that there was 4 states that first received funding, and then every year, just kind of a few more states joined on, applied for funding, and received grants. So it wasn't until 2014 that the 3 freely associated states applied for and received that state partnership grant funding. So one thing important to note, and this kind of is inclusive of the origins of the EMSC program, is, currently when we think of EMS or emergency medical services, we really think of pre-hospital care or out of hospital care. And as it relates to the EMS for Children program, EMS is really inclusive of all systems of emergency care, so not just that pre-hospital focus. So for state partnership program funding, currently the average annual funding for the grant years 2023 through 2027 is about $178,000, and this reflects the first increase of funding since the late 2000s. That funding level was $130,000, and prior to the mid-2000s, it was $115,000. So that the program has not seen a lot of funding increases, and there are a lot of states where that money really is just funds the state partnership program manager and administrative duties and overhead. So there's not a lot of money left over for the actual work of the program. Which I just mentioned that because you'll see in later slides that a lot is being done, and our program managers really are very innovative in how to get the program moving forward. So until this last funding cycle, state governments and generally the EMS office would get the first right of refusal to manage the grant. So if the state didn't want to take the grant, sorry, having just, my mind just went vacant for a moment. Schools of medicine would then take the grant on. So about a quarter of the current grants are housed in schools of medicine, and the rest of the grants are within either the EMS office, and there's maybe 2 or 3 that are not within the EMS office, but within the Department of Health. There is a third model where the state may be getting the funding, but they're passing that funding through a contractor who is managing that grant. Next slide, please. So the purpose of these state partnership grants in the beginning was really to support activities that represented the next logical step to institutionalize EMSC within the emergency care systems and continuing to improve and refine EMSC. So these proposed activities were to be consistent with the documented needs of the state. So those were coming from the prior needs assessment that were some of the original funded grants, and was a logical progression of enhancing pediatric capabilities within the system. So each state, territory, or jurisdiction really focused on the unique and specific needs of their population. So you might have 56 grants out there, but there's probably 56 different programs, different things being focused on and worked on. Next slide. So this brings us to the performance measures, or what has been known as the end of the MUGs and HUGs era. Many of the measures that I will be talking about really came from the 2006 Institute of Medicine report series called The Future of Emergency Care. And one of the reports from this series was the Emergency Care for Children Growing Pains. And it's a pretty hefty tome and had a lot of recommendations in it. And so a lot of what you'll be seeing really was pulled from the work from that report series. Next slide. All right, so our first generation of performance measures, which were active from 2006 to 2017, were focused on pre-hospital measures, a couple hospital measures, and then one that was really looking at institutionalizing the EMSC program. So for our pre-hospital measures, grantees were working to ensure that ambulances carried nationally recommended pediatric equipment and were not already included. They were working on adding pediatric-specific recertification requirements to the relicensure process for pre-hospital clinicians. So while there's always been like requirements for relicensing and continuing education hours, children have always kind of been lumped into this like special population. So there's some places that you could probably get recertified and never take a pediatric class to get that recertification. And then the third measure focused on ensuring that pediatric medical direction, both on and offline, was available to all pre-hospital providers. The hospital measures were focused on creating a standardized recognition program for hospitals that were able to stabilize and manage pediatric medical and traumatic injuries, as well as ensuring hospitals had transfer agreements and guidelines that address pediatrics. So while here these are just 2 bullet points, they really ended up being 4 separate measures. So the hospital measure was one's a standardized system for medical emergencies, a standardized system for traumatic emergencies, and then transfer agreements. And the 4th one was transfer guidelines. So the 5th, or the last measure here in orange, the idea behind this one was really that if EMSC grant funding were to go away, the state would be able to continue improving the system of care for children because they had been incorporating these important metrics into state rule and policy. Next slide. So our second generation of performance measures were active from 2017 up until just last year. And all of the 3 pre-hospital measures that they had been focused on for the prior 10, 11 years had been retired as active measures, although they moved them down into the integration measures. So they were the equipment, online, offline medical control, all of that was still considered a program priority, but it wasn't something that was included in data collection and an active focus for program managers. So these 3 new measures focused on shifting to ensure EMS agencies were submitting patient care reports to the National EMS Information System, or NEMSIS, that data was compliant to the NEMSIS system and was being submitted up to this date. So this measure is recognizing that if we don't have accurate and consistent data, we can't improve our systems of care. Our next measure helps to ensure that EMS agencies have an individual designated who coordinates pediatric emergency care. And this individual is referred to as a PEC, or Pediatric Emergency Care Coordinator, or some states refer to this individual as a pediatric champion. So this was another one of the concepts that was pulled out of the IOM growing pains report. And the report did indicate that the pediatric champion is very important in both hospital and pre-hospital systems. But for this measure, or this generation of measures, it was only included in the pre-hospital world. And then, since states have made such great progress in ensuring ambulances carried the correct equipment, the next logical step was to ensure that the clinicians actually knew how to use that equipment. So it has been shown in multiple studies that muscle memory fades pretty quickly when not used. And since pediatrics account for such a low percentage of EMS calls, it was recognized that it's important that these pediatric skills are included in ongoing trainings. And then you'll see that the hospital and integration measures were left unchanged. Next slide. So up to current, our third generation of performance measures, which became active in April last year, this really shows a shift in the EMSC program's focus to pediatric readiness. So you'll see that our red measures are the pre-hospital measures, and therefore measures, we've kept the PEC measure, so that stayed there, as well as a skills checking measure. But the more important measure now is that states are looking to establish a standardized pediatric readiness recognition program for EMS agencies. So similar to the emergency department recognition program, a new focus on creating those for EMS agencies as well. And then a fourth measure under the pre-hospital measure is ensuring disaster plans address the needs of children. For the hospital measures, we're keeping the recognition program, but now traumatic and medical injuries are all just lumped into one standard readiness program. So there's not a need for two separate medical or trauma recognition programs. It's all integrated into one. The one new measure for hospitals is now designating that PEC in the ED, and also ensuring that staff are weighing and recording children's weight in kilograms. And similar to the pre-hospital measure, also ensuring that disaster plans address the needs of children. Additionally, a new measure is prioritizing and advancing family partnership. So since the late 90s, the EMSC program has had a family advisory network. And since the establishment of the performance measures and part of the integration and institutionalization measure has been the requirement that state partnership programs have a family representative that sits on their advisory committee. So this new measure really kind of bumps that family advisor up to a performance measure and working to ensure that they are integrated into the EMS for Children system within the state or a territory. All right, next slide. So who does all of this work? That's enters our state partnership program managers, or who we could probably consider our state level pediatric emergency care champion. So we're going to take a quick look at what our program managers do and why their role is so important. So next page. So at their core, state partnership program managers build lasting relationships with hospitals and pre-hospital clinicians, administrators, and other experts who directly impact pediatric emergency care. So essentially, they are the go-to person for all things pediatric emergency care in your state or territory. Next slide. So as you saw from the performance measure list, the state partnership program managers have a lot to do, and they are coordinating a lot of pediatric emergency care in both the hospital and pre-hospital systems, ensuring that clinicians at all levels are prepared and confident to care for children. So considering all of that, we can really think of them as a single lead pediatric voice for emergency systems in your state. So their overarching goal is to unify key stakeholders to drive integration of pediatrics into emergency care systems. And I really put that emphasis on integration because this is not and never has been about creating a separate system of care for pediatrics. So this, as they work to integrate EMSC priorities, they're creating the infrastructure for pediatrics to be embedded in the state healthcare politics and infrastructure. And as I mentioned before, they're really connected with key stakeholders who understand the culture within their state systems of care and understand the drivers necessary to affect that change. So with the EMSC program priorities at the forefront, our state partnership program managers really are the stewards of all EMSC initiatives within their state or territory. Next slide. So that said, all of those performance measures, 10 of them, that's not all they do. They are also working on integrating and ensuring that children with special health care needs are taken care of. We have, I believe it was Minnesota who was the first driver in creating a communication card for nonverbal patients. And that was integrated and replicated in at least 3 states, maybe more. And more states are starting to work on and provide sensory kits to EMS agencies for those children who are on the autism spectrum disorder. Illinois specifically created a module that helps address the needs of children in disaster preparedness exercises. Louisiana and Mississippi have been focused on human trafficking issues, and that has also been a topic at some regional symposiums. There's been a lot of injury prevention work, bike rodeos that get organized, safe sleep education, other community events and such. There's been telehealth activities that people have taken part in, just-in-time training. For example, the triple-demic from, well, last year and probably again this year, they're really there to help provide awareness and training for all types of things related to emergency care of children. There's also a great school nurse course guide that's been implemented in a few states that helps both school nurses and those schools without school nurses provide emergency care for children within schools. So that said, the very last square there you'll see is behavioral and mental health awareness, which is why you're all here today. Next slide. So within that behavior and mental health topic, hopefully you all know about the 2019 document, Critical Crossroads, Pediatric Mental Health Care in the Emergency Department document. This was a joint collaborative project with EMSC and the Federal Office of Rural Health Policy. They examined the rising number of children seen in emergency departments experiencing a mental health crisis, the gaps in hospital preparedness to provide continuity of care for these patients, and the impact it's having on children and their families. So this toolkit is the result of the collaboration between these two MCHB, HRSA offices, and serves as the initial effort to address the process and coordination of care for children with mental health care issues. Next slide. Additionally, the EIIC ran the ED Stop Suicide Collaborative. It was active in 2023, and the purpose of this collaborative was to bring together ED-based teams from across the nation with experts in pediatric mental health to exchange evidence-based best practices and optimize the care and follow-up of children and adolescents presenting with acute suicidality. Oh, and thank you, Hannah, for posting that Critical Crossroads document in the chat. Next slide. All right, so that takes us to where do the PMHCA programs and state partnership programs intersect? And I'm not going to talk about this too much because obviously we have a group of people who have been doing this, and I don't want to take up too much more time. But as you've seen from the performance measures since 2007, programs have been working towards creating ED pediatric recognition programs. Many of these current recognition programs use the Pediatric Readiness in the Emergency Department Joint Policy Statement as a foundational resource for their program. And within that policy statement, it does include a recommendation that social and behavioral health issues are included as a recommended policy or procedural protocol. So it's a very minor little bullet point within this whole scheme of the state partnership program, but obviously mental health is a huge issue right now, and there are some states who are looking to try and formalize this within their programs as well. I believe just one more slide. Yes, so how do you connect with your state partnership program managers? That QR code is going to take you to our grants database. And from there, you can go find your state partnership program manager's name and contact information. So with that, I'm going to take a deep breath and hand it back to Anna. And thank you, everybody, for joining today. And I look forward to hearing from our Delaware teams.
Thank you, Rachel, so much. Really appreciate this insightful information. Please hang out till we get a question time. There could be some questions at the end. And I just wanted to show next slide for the folks who are interested to connect with PMHCA's teams. And I have a website here as well, and we'll share this after the fact, how you can connect to the team in your state. And so with no further ado, I introduce you to the Delaware team that have been working together, I believe, beginning of last year, but I'll let them describe their partnership. And I do think that Crystal will be our next presenter. Welcome, Crystal.
Good afternoon, everyone. My name is Crystal Spence, and I've been with the EMSC program with Delaware. I am one of those few that Rachel spoke of, that the grant is managed by a contractor. So I work with Delta, but it's housed with the EMS office, rather, the Department of Public Health EMS office. So with that said, I'm going to keep it brief because I know I only have a few minutes for my part, but you can go to the next slide. I'll just start with how Joe reached out to me. I don't remember the date or the time frame. It was probably about 6 months ago, if I had to guess, Joe. I'm not really sure. And he kind of introduced himself, and I really wasn't sure what this program was about. He told me there would be a video conference. Could I join it so I could just hear what this program was about? I was like, I have no idea who this guy is. I reached out to my boss. I'm like, who is he? She told me a little bit. I joined the conference. I heard what they were saying. I brought it back to my advisory committee. We have advisory committee and a quality committee. An advisory committee is actually open to the public, and it has all my doctors in the ED. There's a PEC rep for every ED. There's a doctor and a nurse. We've already met that metric years ago. And so they come to every single one of these meetings. I also have like the death child review board member, our fan rep. There's a whole lot, a really long list of that. So we allow people to come in there. We have a speaker every meeting, it's every quarter. And the committee kind of decides what they want to learn or what they want to hear of. And the funny thing is they were talking about behavioral health and how to manage these children in the ED. So it was just funny to me that this had been a topic several times, and then shortly after Joe had reached out. So what I decided to do was talk to the committee and see if I could invite them, let them speak about their program, tell us what they're about and what they could provide for us. And Joe and Rosalia very graciously accepted, came in. I'll let Joe talk about that aspect of it, but he told us about this program. And after that meeting, I thought it would be really important to continue this relationship. And I invited Rosalia and Joe to be a part of the advisory board, to come every quarter and give us updates of what's going on with this program and how this can impact the children of Delaware, and what can we do as a team to work together. So we're still in our infancy, but Joe did come speak. Rosalia did come back to the next meeting, and I'm happy to say that we've invited one of their providers to come speak at the meeting to maybe kind of give them like a little educational session on maybe something they could try or use in their specific settings. So I have currently 11 facilities, and we'll have one more facility recognized. We've stayed at 100%. We just have a new facility that's opened this year, and we'll have all 12 recognized. And so that gives Joe and Rosalia access to every facility in the state, ED wise, and several doctors, but at least one doctor, one nurse from each facility, but they always bring extras, and several other members in the state. And I think I've talked about all of those topics, and then I think it goes to Joe now and Rosalia.
Can we get the next slide? So thanks a lot, Crystal. As Anna mentioned earlier, my name's Joe Hughes, and she said I could tell a little bit about myself when I get that opportunity. So I'm going to take that opportunity right now. I am actually retired from the state of Delaware after 25 years of service and have been a consultant now for another 9 years. But so during my 25 years as a state employee, 8 of those years were with the Division of Public Health from 2002 through 2010. So during that time, I was with the Office of Emergency Preparedness, and that was co-located with the Office of Emergency Medical Services, EMS. I also happened to be right next door to the EMSC coordinator, so I learned a lot about that program. I also was very involved in the hospital preparedness program. So I was already familiar with some of the people that were on that advisory board, some of the work they were doing in the EMSC program. So I fortunately, through osmosis, I learned a lot about it just by being next door to it. And then when we started the PMHCA program here in Delaware, the Delaware Child Psychiatry Access Program, we were one of the first cohort of grantees back in 2018. And somewhere along the line, I'd like to say either year 2 or 3, HRSA had reached out to us and asked us, what are some of our ideas for expanding the PMHCA program? And, we had mentioned at that time going into emergency departments and also meeting children in schools. So lo and behold, 2 years later, we're offered funding from HRSA to expand our program to include emergency departments and the school system. So we took that opportunity, and one of my first thoughts was the EMSC program. Just because I was familiar with it, I knew that they were emergency department personnel, they were EMS personnel, and our guidance from HRSA for that expansion program was to address the entire system from entry to exit. So that included, EMS A, EMS B, paramedics, nurses, nursing staff, case managers, social workers, everyone that is involved in emergency department response for children. So that was kind of the attack that we approached, or strategy, I would say, that we approached. And so that led me up to meeting Crystal Spence. Fortunately, I had run into her boss about 3 months prior to reaching out to Crystal, and he had told me that they were now running the EMSC program. So it was easy to do. It was an easy contact. And, I guess I scared Crystal a little bit, reaching out to her without telling her too much about myself. Fortunately, her boss was an old friend of mine, also from Division of Public Health. So I'm glad that I was able to break the ice. I apologize that a lot of you may not have that opportunity for that easy connection. But I wanted to just give, a short list of some of the benefits that we kind of identified as we started approaching this strategy. We have 7 acute care hospitals in Delaware. Crystal mentioned there's 12 facilities. So 12 emergency departments throughout the state. But this opportunity, or this connection between EMSC and PMHCA allows us that, or gives us that access to all 7 acute care hospitals. EMS service providers throughout the state, not all of them are represented on the advisory council that Crystal had mentioned, but it allows us to reach out to those EMS service providers. And again, that's from EMS A and B all the way up to paramedics. We've also talked about reaching out to training administrators in the hospital for the hospital emergency departments. EMSC is located in the Division of Public Health. We as a program are not. We're actually in the children's department. So it really gives us a intro into the Division of Public Health. Not to mention, we are moving to the Division of Public Health, hopefully within the next 6 months. So we're going to end up becoming, I would like to say, sister programs with one another with EMSC. As Crystal mentioned, she's offered us an opportunity to meet with the advisory council on a quarterly basis, give an update. We've got a training coming up next month. And that's one of the primary objectives of this partnership, is offering training and education opportunities. I'm gonna hand that over to Rosie now, and she might be able to give you a little bit more detail because she's much more involved in the minute details. Thank you.
Thank you, Joe. And I'm always learn something new about your connections in Delaware when you present. So Delaware is a small state, and I see that we have people from all over the country. And I'd just like to add that I think one of the best ways to connect with your local EMSC representative is through the leaders on this call. Anna particularly connected us again with Crystal, introduced us as an invaluable resource for the EMSC, and sort of pushed that initial conversation along. So I'd like to just thank you and suggest that while there is a website that you can go to, making a warm handoff is much more effective than making a cold call. So I think that that's a key important thing as you develop your relationship. The second thing is that, as indicated, the EMSC group is extremely busy with all of the other objectives that they had, pre-hospital, hospital, and larger objectives. And so that last slide that we showed with all the other buckets of information is where I think that the Delaware Child Psychiatry Actress Program is going to be able to have a voice. So behavioral health and mental health, but it's one of 12 that still is absolutely critical. So being at the table and having a voice and having the opportunity to tell the story over and over again is very important. The director and the chair of the board of the EMSC wrote a very comprehensive email explaining what issues exist in the emergency rooms with pediatric patients. There was, it was in my opinion, very specific needs that they have. What is the bigger picture for Delaware in supporting mental health before they get to the emergency rooms? When they're in the emergency rooms, how do doctors handle behaviors? How do they involve the family? What do they do if there's, they need the bed? There are so many layers that can be peeled back, and having our team at the table, hearing what those needs are and being able to provide consultation, I think is going to be very valuable. And I was inspired by some of the things that other states have done. I'd like Delaware to be one of the first that creates templates and guidelines for emergency room personnel to handle pediatric psychiatry, pediatric mental health and behavioral health issues. We're a small state, but we have the same problem that everyone else has, which is not enough beds, not enough providers, and a spike in the needs. So this is our first year. I think as you develop your relationships with EMSCs, and I encourage you to do so, start at the beginning. It's a relationship building. Present the ideas and tell about your program. Ours is consultation. We have a learning management system, and many people in the EMSC have already signed up for our learning management system, where there's over 50 courses that they can take, hour-long courses about behavioral health. And then we have our I'm just totally blanking like someone else did earlier. Anyway, we have the key components of our program: consultation, training, and resource and referrals. And while everyone knows, Delaware's small, we all think we know about the newest provider or service that can be provided for that child. I think a transition of care from the emergency room back into the community is really important. And there's no possible way that one hospital or person working in the hospital can know what the best system of care is for that child after they leave the emergency room. And so the Delaware Child Psychiatry Access Program hopes to help and create resources and referrals and templates for children, or at least a voice that can help the EDs transition that child back into the community. So Dr. Borer, who's our child psychiatrist, who's presenting in February, has a long list of things that he'd like to share with the emergency room doctors, but you know, there's a lot to choose. So we expect that this is going to be ongoing training and education, and that's how we're going to develop the relationship and be able to be of service to the community. That's all I've got.
Thank you. Thank you, everyone. Thank you to all our speakers. Is this our last slide? I just wanted to make sure that we didn't miss any information. All right, it is our last slide. This one is blank for questions. Are there questions, suggestions to any of the speakers, these incredible individuals who helped us put this webinar together? Please either drop them in the chat or just unmute yourself, and we'll just hang out here for a little bit. I do want to remind folks that we do have on February 22nd at 1 p.m. Eastern Time, a collaborative where all our introduction collaborative webinar, where all folks on this call are invited to register or to actually save the time on your calendar. Please log into our website. We'll drop it in the chat, and I'll put that on your calendar. I'm just, by listening to this incredible presenters, I have goosebumps. I'm hoping that we are starting to break up some of the silos and working together. It's an incredible partnership, and so much of optimism for the future and things to come for the kiddos in each and every family, in each and every state.
Anna,
so with that,
I do have
go
one
ahead.
question in the chat. If Crystal could just share a little bit about what her role is with the program, not only who you work for Delta, but what your role is.
I'm sorry, I don't see the question in the chat. What specifically are they asking?
It was a direct question to me, which is, what is your role with the EMSC?
Okay, so they want to know what my role is.
Yes.
Okay, so I'm the manager for the state of Delaware. So all that stuff that Rachel talked about, all those metrics, all the initiatives, all that, I'm kind of like the one, like she says, we get the professionals, all the doctors, all the nurses, we get all these people together, and we make sure we find a way to meet these metrics. I could go into full detail, but basically we have quarterly meetings. We talk about these metrics, how we're going to meet them, what we've done, what we're doing. And for this specific program, they're giving us an opportunity to kind of, bring it in how we want to bring it in and see how we can work it, which they kind of do with a lot of this stuff, which I really like, because every state's needs are very different and how you get things done are very different. So I'm the manager for the state of Delaware. If that doesn't answer your question, you have more specific, let me know. I could go on and on. I don't want to do that.
I think there might be some appetite, Rosie, for others to learn more about how to connect to somebody like Crystal and their state. With that, I believe there was a slide there Rachel pointed out before, but also certainly reach out to myself or Jen, Jonathan, our EIC team for that connection. Rachel, is this something that is going to be possible in the future, you think, Rachel Alter? I'm not sure if she got off or not.
I'm sorry, I'm still here. I thought my video was active. If what's possible?
If we have a PMHCA program who wanted to connect to the EMSC program in their state.
Yeah, absolutely. I'll drop the link in, but I can also, I'll put it might be just easier to connect with me. Arguably our grants database is maybe that intuitive. So people can also email me and I can connect them, but let me also drop in our database link as well.
Thank you. Rosie, I'm sorry I interrupted you.
No, that I just think that there's a real I don't know if appetite is the right word, but a real need, and behavioral health, I think, is is rising to the top of the priority list for emergency rooms. When a patient has to take up a bed and is there for longer than they couldn't really, when they longer than they can support that patient's needs, or because there isn't a place to transition them in the state, or because care hasn't been given at the pediatric, primary care physician level, or because of the family dynamics, whatever those issues are, I think mental health and behavioral health is definitely a priority, certainly in our state. So I appreciate that Crystal's raising it and bringing it to the attention of their advisory board. But from what I understand, they've also been talking about it. While it's not one of the objectives that Rachel mentioned, they've been talking about it. It's real. It impacts everything that they do every day. And so having standards and some structure around that particular bullet, I think is going to be a real benefit for the whole country, in my opinion.
Yeah, Rosalie, we have been talking about it since 2016, but because there's never been any answers or what can you do about it, it was kind of just passing around best ideas to manage it as what with the resources they have, which is almost nothing. So it's really exciting that this program is coming up and maybe can address some of this. So we talk about it and then we table it, because like, what else can you do?
And I'm sure that there are many programs on this call that have other developed ideas already existing in your programs that you can bring to the emergency room. So I liked what Rachel said about the uniqueness of each state. Tailor it to what your state's needs are, and but bite off of every, bite off what you can chew.
More importantly than anything else, I wanted to point out, Rosie, is the fact that from that first meeting we went to back in August, we heard what they needed. We heard some of what they needed, and that allowed you and I to bring it back to the PMHCA program and say, how can we address some of these needs? So we've been talking about it too. It has started the conversation all over again. Glad it was tabled back in 2016 temporarily and brought back up. So, all we can do is try. And that's what, at least it's in the conversation.
Thank you, everyone. Are there questions or suggestions, or is there something your state is doing you'd like to share with us here? All right, hearing none, if the thought comes in mind, please feel free to email myself or Rachel, and our information is in the chat. We are looking forward to nurture the relationships before in front of us with PMHCAs and EMSC state partners, and see what we can help each other with. I do want to put a plug in real quick that we will have a webinar coming up in a few weeks on January 30th at 3 p.m. Eastern time. The topic will be mental health emergencies during times of disasters and how PMHCAs can get involved. With that, I'm going to stop the recording and hang out just for a few minutes. If you guys wanted to